Welcome to this special lecture series on juvenile and adolescent hypermobility spectrum disorders, a parent's guide to assessment and management. I'm a physiotherapist. My name is Judith Orban, and my clinical focus is on complex and chronic conditions, particularly connective tissue disorders, Ehlers-Danlos syndrome, hypermobility spectrum disorders, as well as long COVID and chronic pain syndromes. As a Schroth therapist, I also work with pediatric idiopathic and adult degenerative spinal conditions such as scoliosis and kyphosis. My approach blends manual therapy, functional assessment, and holistic methods, which I refine at Diane Associates Physiotherapy Clinic using the integrated systems model. I'm also a registered practitioner with the Ehlers-Danlos Society and the Long COVID The Answers clinicians. The agenda for today is further understanding generalized joint hypermobility and hypermobility spectrum disorders, the unique challenges for children and adolescents, including a new diagnostic framework tool for assessment of kids and teens, hypermobility-related conditions, such as dysautonomia, ME/CFS, and other orthopedic conditions that occurs in this population, genetic testing and inheritance patterns, and also discussing the differences in care and management, practical tips for parents and caregivers. The presentation will be 60 minutes long approximately, followed by Q&A. If you would like to, you can type in your question in the Q&A box, or you can type it in after the presentation as well. Okay, so a quick introduction to hypermobility. In the realm of hypermobility, we see diverse presentations. Some individuals experience no health issues at all, while others develop symptoms early in life that may necessitate careful management and treatment. Additionally, there are those who remain asymptomatic until a specific health trigger later brings symptoms to the forefront. Today, our focus is on understanding when hypermobility may become problematic in children, how to approach diagnosis thoughtfully, and where to direct attention in your child's care. But it's essential to remember that social media does not replace a clinical setting. Sharing information with a broad audience, if you see this presentation later on, because during the recording, it requires sensitivity to avoid fostering unnecessary worry. Ideally, use this knowledge to guide productive discussions with your healthcare provider, advocating for your child and their well-being. So what is joint hypermobility? Joint hypermobility refers to a greater than average range of motion in the joints. In simple terms, a joint with hypermobility can bend and stretch further than usual without damage. This flexibility occurs because the connective tissues, such as ligaments and tendons, are more elastic than usual. Joint instability is when the structures supporting a joint, such as muscles, ligaments, tendons, struggle to maintain its proper alignment during movement. Imagine a door with loose hinges. Even with minimal pressure, it may swing more freely than intended. Similarly, a joint with instability lacks control and support to remain secure, increasing the likelihood of minor misalignments and making daily activities more challenging. While instability can lead to frequent sprains and pain or other functional issues, not all hypermobile joints are unstable, as some individuals have sufficient muscular control or structural stability to manage the increased range without any instability. However, if there's inadequate support around a hypermobile joint, such as weak muscles, instability can potentially cause joint damage over time. Now let's discuss the difference between subluxation and dislocation. This is a topic that comes up quite frequently along hypermobility and instability. Subluxation is a partial dislocation where the joint partially moves out of place, but not entirely. This can cause discomfort, pain, temporary changes in the function until it returns to its normal alignment as the joint heals. In hypermobile children, subluxations can happen with less force due to their joints' increased laxity. Dislocation is more severe than subluxation. Here, the joint completely exits its usual position, requiring an external force or assistance to be realigned. Dislocations can be painful and may damage surrounding tissues over time. A sprain occurs when the ligaments, so the soft tissue connecting bones within a joint, are overstretched or torn due to a force that pushes the joint beyond its usual range of motion. This commonly results in pain, swelling, reduced stability, but does not usually alter the position of the bones in the joint. And it commonly occurs also along with fractures. So now that we understand what is hypermobility, instability, let's look at what is hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders in general. Ehlers-Danlos syndromes are a group of connective tissue disorders that can be inherited and are varied both in how they affect the body in their genetic causes. They are generally characterized by joint hypermobility, skin hyperextensibility, and tissue fragility, such as easily bruising. EDS was classified into subtypes based on their clinical presentation and molecular genetic background. The Ehlers-Danlos Society is an international organization focused on advancing research, education, advocacy, and support of Ehlers-Danlos syndromes and also hypermobility spectrum disorders. Their mission includes increasing global awareness, supporting medical and scientific research, and fostering patient-centered resources to improve the quality of life for those who are affected by these complex connective tissue disorders. It's important to note that the hypermobile type Ehlers-Danlos syndrome is the most common of all EDS subtypes, accounting for 90% of the cases. And among the general population, it's about 1 in 3 to 5,000, although a newer, smaller research has shown 1 in 500. Hypermobile EDS causes generalized joint hypermobility, joint instability, chronic pain, mild skin hyperextensibility, and abnormal scarring. But also, there are other related conditions that affect many different areas of the body. Just think of how many of our organs and tissues have collagen. So it may cause chronic fatigue, gastrointestinal issues, dysautonomia, headaches, mast cell activation diseases, and the list goes on. The 2017 diagnostic criteria for adults does not fully reflect on these findings. So there was a need to develop something that is a little bit more comprehensive. If we take a look at the adult diagnostic tool that was developed in 2017, the first criterion is generalized joint hypermobility. The second criterion contains manifestations of connective tissue disorders, such as skin, pelvic health, dental, and cardiac signs. It requires positive family history, and it also appreciates the musculoskeletal complications that is typically a 3 out of 3 among patients with recurring pain and joint dislocations. Criterion 3 discusses the absence of other types of Ehlers-Danlos syndrome, so it's important to exclude patients from the HEDS criteria who are qualifying for other types of EDSs, and also excluding heritable and acquired connective tissue disorders, including autoimmune rheumatologic conditions and other neurodegenerative conditions. I would like to also discuss, before we move on to the children's criteria, the hypermobility spectrum disorders, such as HSD. There are connective tissue disorders that cause joint hypermobility, instability, injury, pain, similarly to HEDS. These patients, though, don't fit the 2017 diagnostic criteria, and their symptomatic joint hypermobility cannot be explained by other conditions. A person with HSD may have also other medical issues, as we talked about before, such as chronic fatigue, headaches, GI problems, and autonomic dysfunction. Currently, we do not know if HSD is a genetic disorder. Now let's take a look at the new studies and framework for pediatric joint hypermobility. We will be talking about 3 important studies. The first one will be, and the most comprehensive discussion will be along the Pediatric Diagnostic Framework Update. The Ehlers-Danlos Society recently released a new framework specifically for diagnosing joint hypermobility in children. Then we will take a look at the SPIDER study. This is fresh off the press from last month, new screening tool developed for adolescents with symptomatic hypermobility. And then we will take a look at gender and pubertal influences on joint laxity from a study by Quatman. So the need for new diagnostic tools arises from multiple issues. The diagnosis of hypermobile EDS, hypermobility spectrum disorders, currently relies on clinical evaluation as there are no established biomarkers such as genetic background. The clinical criteria developed for adults was challenging to apply to children and biologically immature adolescents, given the differences in the musculoskeletal development. A fundamental requirement for diagnosing HEDS and generalized HSD is the presence of generalized hypermobility. So in order to qualify for these conditions, there has to be a presence of generalized joint hypermobility. However, current literature shows that a significant number of children meet the criteria for hypermobility. Moreover, many comorbidities that we associate with HEDS and HSD are also commonly occurring in the general pediatric and adolescent populations. For these reasons, there was a pressing need for pediatric-specific diagnostic criteria to ensure accurate and effective identification of these conditions in younger populations. So let's talk about generalized joint hypermobility in children to get a little bit of an understanding how it presents overall among all children. Studies show that about 20 to 30% of children aged 3 to 10 exhibit generalized joint hypermobility, but the prevalence drops to 5 to 10% in adolescents as their tissues mature. Generalized joint hypermobility is generally more common in girls, about 1.5 to 2 times more than boys, and varies by region and ethnicity, with higher rates among African, Asian, and Middle Eastern populations. Around 8 to 10% of hypomobile children report chronic joint muscle pain, mainly in the lower limbs, affecting mobility and quality of life. Functional limitations such as difficulty climbing stairs or running are reported 15 to 25% of cases. Injury risk is also elevated with hypermobile children, facing 2 to 3 times higher likelihood of recurrent sprains and dislocations. Up to 70% of benign symptoms like joint aches and 10 to 30% face motor skill delays or developmental coordination disorders. Psychosocially, around 30% report anxiety, potentially linked to challenges of managing pain and joint instability. The key importance in developing these new guidelines, so kind of a summary again, what we just discussed, that children should not be diagnosed with hypomobile Ehlers-Danlos syndrome using the 2017 criteria until they reach biological maturity, as natural joint hypermobility is common in youth and declines with age, often later in girls than boys. Skin changes, scars, musculoskeletal complications may develop at varying stages, making early diagnosis challenging. So to address this pediatric framework has been developed. This allows for fluid diagnosis, enabling children with generalized joint hypermobility to be reclassified even over time. A pediatric generalized hypermobility spectrum disorder diagnosis helps guide appropriate care without over-medicalizing, but recognizing hypermobility as a common trait while distinguishing those with musculoskeletal issues or potential HEDS as they mature into full skeletal maturity. So let's take a look at this diagnostic framework. The Pediatric Working Group of the International Consortium on Ehlers-Danlos syndromes and hypermobility spectrum disorders met over 2020 and 2022 to review the 2017 diagnostic criteria. And they created and published in May 2023 a new diagnostic framework to assess children to adolescents age 5 up to biological maturity. If you would like to find this study, I include the picture at the bottom of the stage with the references, and I believe it will pop up more often so you can find it easily. So taking a look at the diagnostic tool, we will dissect this into many pieces to make sure that you understand it fully. So it has 2 pages. The first page is the actual diagnostic form, and the second page includes the 8 domains of different pediatric joint hypermobility diagnosis. If we take a look at the 2017 adult criteria, you can see that on the left side of the screen. Again, we discussed it has criterion 1, the generalized joint hypermobility. The new questionnaire for children also has the Beighton score. The criterion 2, where we had 3 different sections, looks very different on the new pediatric form. We have specific skin and tissue abnormalities, musculoskeletal complications, and comorbidities. And the criterion 3 has been mentioned at the bottom as prerequisites. Okay, so let's take a look at from a bird's eye view first on the main differences. In children, generalized joint hypermobility is indicated by a Beighton score of 6 or greater. This is 1 point higher than the adult threshold due to the typical higher flexibility in youth. We will discuss this in more details in a second. Also, the new framework introduces 8 classification subcategories for children based on the presence of these 3 categories: musculoskeletal complications, skin and tissue abnormalities, and comorbidities. The core comorbidities are included for their established impact on disability, and I really appreciate this extra category that's lacking from the adult clinical criteria. This structured approach allows individualized support by categorizing based on each child's specific needs, depending whether if it's skin and tissue abnormality, musculoskeletal complication, or a core comorbidity. Okay, so let's see how we can use this diagnostic tool in a clinical setting. Obviously, most of you are parents tuning into this presentation, so this is just a little bit of an information for you to see how it looks like, but some of you might be healthcare professionals, so you can actually learn how to utilize this tool. So it's important to mention as we take a look at the first section, children from 5 years of age until biological maturity, what does this mean? So we have this age criteria of 5 years old as a minimum. And the reason for that is that infants and toddlers lack sufficient bone maturity for a clinical, meaningful assessment. Adolescents reaching biological maturity before 18 should be reassessed with the 2017 criteria. And let's discuss what this biological maturity means. On the right side, you can see pictures from a study by Manzetti. I placed here the research stage of the pelvic bones, the Sanders score of the hand bones, the distal radius and ulna indexes, and the thumb ossification composite index. So these are certain different ways how we can define bone age from x-rays in different areas of pediatric clinical settings. We use different types of bone age x-rays. In the scoliosis world, we prioritize the Sanders score and the research stage from the pelvic bone. But biological maturity can be also defined by the completion of puberty, a growth rate less than 1 centimeter per year that is measured over a minimum of 3 months, at least 2 separate assessments, not just by the bony x-ray. But obviously, this would be more accurate. So now if you have a child that is fitting this age criteria, the next step is to look at the Beighton score. I place a picture from the questionnaire at the right bottom of the page, so you can see the same picture from the actual questionnaire. You can see the pictures are similar to the ones on the Ehlers-Danlos Society's Beighton scoring system. So we look at the hyperextensibility of the thumbs, the little fingers, the knees, the elbows, and the spine. I'm not going to get into details how to do this because that is not the purpose of this presentation, but I just wanted to have a little reminder and you can always double check these information on the Ehlers-Danlos Society's website if you need to. So let's say your child scores 6 out of 9 on the Biden score. That is the minimum to indicate generalized joint hypermobility. There are differences between sexes and observed in age, but it is basically due to limited data on biological maturity. So they kept it 6 out of 9. In adults above age 18, it is 5 out of 9. The Biden score is a quick and reliable tool, but more detailed assessment is necessary for clinical planning and research. It is important that a comprehensive musculoskeletal exam, including neurological, skeletal assessments, should accompany Biden scoring to evaluate each symptomatic joint thoroughly. I've seen many kids who score negative in standing for the knees, and when the hamstring muscles I placed in less extensive forces supporting the body, they actually score over 10 degrees of hyperextension for their knees. So although this is an efficient and quick tool and quite reliable, there are some kids who might fall off the criteria due to specific neurological and skeletal assessments. So it's best done with a well-seasoned physiotherapist, orthopedic doctor, rheumatologist, or pediatrician. And here are some other complications. We have different types of hypermobility, and this questionnaire is beautifully reflecting on the fact that they are testing for generalized joint hypermobility, meaning that is throughout the body. We also have peripheral joint hypermobility impacting hands or feet, and those kids won't fit 6 out of 9 on the Biden score. So technically, they cannot be completed for the whole assessment, but I will talk more about this, what to do in those scenarios. We also see localized joint hypermobility, which is a single joint or group of joints in the same area, so not generalized. And I also have a patient, a teenage girl with a rare genetic condition that affected her while she was below age 10 with generalized joint hypermobility. And as she went through her skeletal maturation, she is now 0 out of 9 on the Biden scale. So she has a history of joint hypermobility throughout the body. So we do see other types of hypermobility. So make sure that you're aware that this questionnaire is designed for generalized hypermobility spectrum disorders, but there is a statement that I will discuss very soon. What does the Ehlers-Danlos Society recommend in these scenarios? Okay, next section is skin features in pediatric hypermobility assessment. So on the right side of the page, again, you can see that we have 1, 2, 3, 4, 5, 6 scores on unusually soft and velvety skin, mild skin hyperextensibility, unexplained stretch marks, atrophic scarring, the bilateral pyogenic papules, and recurrent hernia. And there are some additional notes and changes to the adult version of the questionnaire. So to assess skin involvement, at least 3 of 5 features, well, this is 6, must be present. The requirement for atrophic scars has been adjusted from 2 to 1. So in the adult, you have to have 2 areas. In children, 1 is enough. It recognizes that young children may not have significant scarring yet. I see this as a downfall of the questionnaire. I would say 9 out of 10 children cannot show me a scarring because it's just not present, because they haven't had any major issues. And also the unexplained stretch marks are quite rare before the adolescent growth spurt. So it is quite difficult to test positive on the skin and tissue abnormality, I find. Hernias such as congenital umbilical hernia and inguinal hernias are common in pediatric populations. Therefore, these should not be counted. However, the recurrent hernia are unusual and indicate tissue fragility. I cannot comment on this, so this is the rule on hernias. Okay, so there must be a minimum of 3 out of 6 to score positive on skin and tissue abnormalities. Next one is musculoskeletal complications. So here they discuss 3 major domains such as joint pain, injury risks, and soft tissue injuries. So the first one is episodic activity-related pain. Second one is recurrent dislocation subluxations in the absence of trauma, and soft tissue injuries. And here they distinguish between one major that needs surgical repair or recurrent multiple minor tendon or ligament tears. Children with generalized joint hypermobility often experience joint pain, particularly in the knees, feet, and ankles. Evaluating painful joints for instability can help identify treatable issues. Adolescents are more likely to experience patella, the kneecap dislocations, and report joint instability, especially in the knees, ankles, and shoulders. Young athletes with hypermobility are 3 times more likely to sustain shoulder injuries. And finally, adolescents with joint hypermobility are at a higher risk for soft tissue injuries, particularly in the knees, underscoring the need for regular monitoring of joint health in active children. I find that for those children who have a number causing complications in this section will test very easily positive, and those who not really testing positive, they have usually 0 out of 3. So this one is very accurate, I find. Now let's take a look at the third part of this questionnaire, the comorbid conditions in hypermobility. So comorbid conditions are health issues that occur alongside hypermobility and have been observed in at least 10% of the cohort studies. They can complicate a child's overall health picture, but do not alter the primary diagnosis. They are coexisting. And some children might have multiple comorbidities along with hypermobility spectrum disorder or generalized hypermobility, and others might have none. So the most common ones and the ones that are listed in the questionnaire are chronic primary pain, chronic fatigue, functional gut disorders, functional bladder disorders, dysautonomia, and anxiety. And here it's a yes or no question. Are there any number causing this stressor disability? Yes and no. And you can check which ones are the ones that are part of your child's comorbidity. Now, so the difficulty with this questionnaire is that in order to be able to diagnose comorbidities, the person who's performing the assessment has to be perfectly aware how to diagnose properly chronic primary pain, chronic fatigue, functional GI disorders, functional bladder disorders, primary dysautonomia, and anxiety. So it's not just like a quick, do you think you have this? But this has to be established in a strict clinical setting, oftentimes with a specialist who knows exactly which criteria, questionnaire, or clinical testing, or diagnostic testing, or genetic testing to reach for. So this is the area that's a little bit more under development, and we have the SPIDER study to help with this further. So stay tuned, because we will continue talking about comorbidities and how to assess this without seeing all the specialists that requires to identify these conditions. So when a child with hypermobility experiences distressing or disabling comorbidities, they are categorized into a different subtype to ensure appropriate care and management. So we will be reflecting on this when we diagnose children. I wanted to show you this from the research where this questionnaire was presented. They looked at comorbidities and they looked at comorbid symptoms. And what they found was very interesting, that among children with, let's say, anxiety, have 35% reported fatigue. And among children with chronic fatigue, 30% reported anxiety. So this table of content purely reflects on how comorbidities in populations with another comorbidity exists, and it's important to recognize them. Some of these included, let's say, 45% of people with children with chronic pain had appetite disturbance, and over 50% of them had anxiety with chronic pain. Children with chronic fatigue reported in the functional gastrointestinal disorder section nausea, and they had 20 times more increase in bladder dysfunction. And also with functional gastrointestinal disorders, 94% of them had POTS and orthostatic intolerance, such as dizziness. They had a tilt-table confirmed POTS, not a Nasaline test confirmed POTS. And also 94% of them had fatigue. Look at primary dysautonomia. Almost nearly the highest amount of joint pain, muscle pain reported among patients with primary dysautonomia. Over 90% of them had fatigue and many symptoms of nausea, abdominal pain, constipation, and other issues regarding bowel and bladder control. So very interesting to look at how they impact one another. So let's see now how to classify generalized hypermobility into the 8 new domains. If you are, again, a parent trying to navigate this on your own and you're curious if your child might fitting in and you cannot have access at the very moment to a specialist or a pediatrician or a clinician, you can start with the top of the flow chart. So does the person have generalized joint hypermobility based on the Beighton scale? If it's a no, the person does not have generalized hypermobility. It still can be localized or peripheral. We will talk about that. But if the answer is yes, so the Beighton score is 6 or more out of 9, then the next question is, does the person have musculoskeletal complications? This will distinguish between if it's a generalized joint hypermobility or it's a hypermobility spectrum disorder. If the answer is yes, it's going to be a spectrum disorder. If the answer is no, it will be a generalized joint hypermobility with or without skin involvement or comorbidities. And if it's a yes, there's other musculoskeletal complications involved, then we can have them again with and without the skin and comorbidity complications. So here's how it looks like on the 2 pages PDF document. So the second page is characterized by a first section. So this gray area, between the 2 gray areas, you can see asymptomatic conditions. So this is a pediatric generalized joint hypermobility. So it's presenting with over 6 out of 9, so 6 plus on the Beighton score, but the person does not have skin issues, musculoskeletal complications, or comorbidities. These are the children that needs to be monitored very, very closely. They show with a Beighton score of 6 out of 9, but at the moment, there's no number causing skin issues, musculoskeletal complications, comorbidities. I recently assessed 2 preteen girls, 10 and 12-year-old girls, and one of them where the mother was the mother has been diagnosed with hypermobile Ehlers-Danlos syndrome. And the one that we were really concerned about based on the subjective symptoms scored asymptomatic. So the first row, we are absolutely shocked. And the one that never complains about musculoskeletal complications, scored actually positive for everything, which was very, very shocking with the positive skin issues and the comorbidities. So both of them needs to be monitored closely in case this is a fluid diagnosis. This can change over time. So in the yellow brackets, again, we have one diagnostic category called pediatric generalized joint hypermobility. And again, you add on if it's with skin involvement, with comorbidities, and with both core comorbidities and skin involvement. And in the green section here, you can see that all of these present with musculoskeletal complications. So these are called from now on pediatric hypermobility spectrum disorders. Okay, so we don't see Ehlers-Danlos anymore, correct? We don't state below skeletal immaturity anymore that it's Ehlers-Danlos syndrome. There was a sentence in one of the studies that if the parents has been diagnosed already with hypermobile Ehlers-Danlos syndrome, the condition can be grandfathered, but I think it's just much easier to use this new diagnostic criteria. And then past skeletal maturity, you can always retest and diagnose through the 2017 adult criteria, unless we have a new one by the time your child grows up. Okay, so now we have this second category, and this pediatric hypermobility spectrum disorder to reflect on what it would be HEDS. Okay, but we don't have HEDS anymore. This is another diagram to look at the different 8 domains. So we have 1, 2, 3, 4, 5, 6, 7. Oh, I thought there's 8. My math is not mathing right now, but yeah, there's 8. So we have, oh yeah, because there's one asymptomatic. So if you look at the musculoskeletal complications with the pediatric generalized hypermobility spectrum disorder subtype, this is where we have musculoskeletal complications, and all the others where we don't, we call them pediatric generalized joint hypermobility. Okay, so these 3 ones at the bottom. So there's some additional information before we wrap up this particular study. Young people's diagnosis can change as symptoms evolve. And as they have, let's say, an ankle sprain, or they have a car accident, unfortunately, or they have another diagnosis. So once they're biologically mature, they should be assessed using the 2017 HEDS criteria. Children diagnosed with HEDS before the new criteria do not need reassessment unless their doctor deems it's necessary. So if your children has been diagnosed 5 years ago or 3 years ago with HEDS, it doesn't change on their condition unless you think it was inaccurate, you think it was not comprehensive, or obviously the clinician thinks and the doctor thinks. The new framework classifies generalized joint hypermobility. Children with localized or peripheral hypermobility may be diagnosed with this kind of like extra note that it's a localized or a peripheral hypermobility spectrum disorder if symptomatic despite a negative Beighton score. So for those of you, because this kind of pops up in the last couple of weeks quite often with the kids I see for assessment, that they scored negative for the Beighton score and they score positive for everything else. And I'm sure many of you who have filled out the HEDS criteria has faced this reality as well. So many of you have a hypermobility spectrum disorder because you do not fit into the HEDS checklist. So it's also important to mention that if you have this questionnaire filled out in a private setting with a physiotherapist, with an OT, or even with your GP, a comprehensive evaluation would be necessary. So it really can only be diagnosed to a very accurate point after ruling out other potential explanations for symptoms. And there we have genetically defined Ehlers-Danlos syndrome, other heritable connective tissue disorders, systemic conditions, chromosomal microdeletions, skeletal dysplasias, neuromuscular disorders. So there are these prerequisites that as a physiotherapist, I cannot do in my clinical setting. So it's important to mention this, that if there is a family hereditary suspicion, or if there's anything else that is a number-causing heritable connective tissue disorder, then you go and further assess your children for those. It wouldn't necessarily change the way they are being treated because the treatment is the same, whether the diagnosis is accurate or not. I want just to mention that. So before we completely wrap up this study, I wanted to add an extra study to this that has been done, I believe, 2-3 years ago, this whole EDS trifecta, the common co-occurring conditions. So POTS and MCAS are increasingly presented in people with EDS, and that's why we call it the EDS triad. And despite it's still difficult to come up with a plausible mechanistic reason as to why they would be related, since HEDS has no known genetic mutations, but is based solely on this clinical criteria. Likewise, mast cell activation syndrome is also not fully based on objective tests. So EDS and MCAS are clinical diagnoses of exclusion, both with relatively new diagnostic criteria. And POT is still quite poorly understood disease or cardiac dysautonomia. There was a recent research where they compared the symptoms, how much are they overlap in HEDS, POTS, and MCAS, and you can see there's plenty in the center. Weakness, fatigue, abdominal pain, nausea, so the functional GI disorders, bloating, constipation, hypotension, exercise intolerance, impaired cognition, headaches, palpitations. And so this study looked at the relationship with all these conditions, and they found that there's no current scientific evidence of any association between the three, researchers believe that the reason behind the association of these three clinical entities stems from an overlapping pool of symptoms. And most of the symptoms are non-specific and vague. So it is very evident that there's a large overlap between the patient-reported symptoms, but they suspect that the overlap may have been misconstrued to reflect comorbidity. Okay, so little note about genetic testing and inheritance, because this commonly pops up along this line. So genetic causes of HEDS have not yet been identified. There is no genetic test for HEDS. Because HEDS is the most common type, accounting for more than 90% of all cases of EDS, most people with EDS will not need genetic testing for diagnosis. It is not necessary for a person with HEDS or HSD to have genetic testing unless there's a reason to suspect that they may have a genetic disorder for which testing is available. Direct-to-consumer testing services such as 23andMe and Ancestry.com are not helpful for diagnosis of any types of EDS and HSD. These products test a relatively small number of single nucleotide polymorphism. SNPs are not the same thing as pathogenic genetic variants. In order to receive an accurate diagnosis and appropriate care, all genetic testing should be ordered and interpreted by a medical professional and not a direct-to-consumer testing service. Now let's talk quickly about inheritance as well. So as many of you are parents with children of question, so HEDS is generally thought to have an autosomal dominant inheritance pattern, meaning that the condition can be caused by one copy of a pathogenic variant. So if a person inherits this variant from their parent, they will develop HEDS. Consequently, each child of an affected parent has a 50% chance of inheriting the pathogenic variant and therefore the condition. If both parents are affected, each child has about 75% chance of having HEDS. However, genetic basis of HEDS is complex, and some individuals may not have a family history of the condition, indicating that it can also be arise sporadically. So it is possible for someone to be the first person in their family with a specific genetic variant. Sometimes genetic disorders are the result of de novo mutations. De novo mutations are changes to the DNA that occur spontaneously due to errors in a germ cell, egg, or sperm of one of the parents. Okay, so now let's take a look at the spider. So the spider is a multisystemic symptom impact tool for adolescents with hypermobility rated disorders. This has been published this year. So we have this new tool to use for our adolescent, and it's a beautiful continuation of the previous research and study. So the two together can very nicely identify both hypermobility spectrum disorders and further details on these hypermobility related disorders. So this new screening tool is to identify how various symptoms affect daily life, guide our treatment pathways, and monitor the effectiveness of the treatment. This is not used for the diagnosis of HSD or HEDS. Instead, it is used to measure the presence and the impact of symptoms that are reported. The SPIDER questionnaire covers 8 domains, such as pain, whether it's acute or chronic, neuromusculoskeletal issues such as joint and muscle problems, fatigue, bladder issues, bowel issues, digestion issues, cardiac dysautonomia, including POTS, and as well as anxiety and depression. The study were completed over several stages with about 11,000 adults and 1,100 adolescents, and the adolescents were 13 to 18 years of age. Among the 1,100 adolescents that participated, over 1,000 were diagnosed with hypermobility spectrum disorders or HEDS, and they had about 118 control group. While the questionnaire has been validated in adolescents, the researchers are now seeking to validate it among adults as well, so it can be performed at any age. It offers really a great assessment of the multisystemic conditions and symptoms in less than 10 minutes. So it's pretty easy to fill it out. So it avoids this time-consuming burden of completing 8 separate questionnaires. And don't forget, when I mentioned that 8 separate questionnaires regarding the domains of the previous questionnaire, it's not as easy to fill out a questionnaire to define if you have chronic pain, if you have chronic fatigue, if you have gut disorders. So it's just an objective measure to see if there's a number causing issue, and not everybody will be perfectly fitting into any questionnaires. So we have obviously lack of confidence to state that if you're scoring negative on the spider domains, you're not going to have this issue, because it might be not fully reflecting on your unique scenario. But it really helps to identify these subgroups and see among your profile which area needs the most care and help. So this is how the spider web looks like. We have, again, the urogenital issues, bowel and bladder, neuromusculoskeletal issues such as joint sprain, joint pain, regular acute chronic pain, chronic fatigue, gut issues, cardiac dysautonomia, depression, anxiety. And you can see how one person looks quite different than another, because person A presents with minimal cardiac issues and minimal gut health problems, and the other person presents with primary fatigue, primary gut issues, and cardiac dysautonomia. So as I mentioned, everybody's spider graph look different, as symptoms can affect each person differently, but the results may also change over time. So you can monitor your symptoms, how they fluctuate, or how they respond to treatment, how they change over time. This is very similar to the previous pie chart that the Ehlers Down Society provided. So the domains are quite similar. I really enjoy working with this domain. So I'm glad that now we can just fill out the spider very quickly and take a look at how each person's hypermobility related symptoms look like. Okay. So now I would like to switch to another big topic before we reflect on how parents can support children. And this alone could be another 1-hour presentation or more. This is just to raise some awareness of the most commonly occurring conditions. So it's important that children with generalized joint hypermobility often face a range of orthopedic issues due to the laxity of connective tissues, which can lead to musculoskeletal imbalances, joint instability, postural concerns. These orthopedic issues underscore the importance of targeted physical therapy. I cannot highlight this anymore. Underscore the importance of targeted physiotherapy. So not necessarily doing physiotherapy because your child has generalized joint hypermobility. Is it symptomatic? Do you have skin issues? Do you have musculoskeletal complications? So you have to, shouldn't target the big umbrella term. You target what is the underlying orthopedic issue that your child deals with. Would it be footwear support, monitoring or managing symptoms, or prevent secondary complications? Early interventions and prevention focusing on neuromuscular control, strength, and proprioceptive training can really help to improve the joint support and reduce the risk of injury. But is it indicated? Is it necessary? If joint pain and arthralgia develops, it's important, obviously, to maintain continuum of care. Many hypermobile children experience joint pain, particularly in the knees, hips, and ankles, and this needs to be addressed because the pain doesn't have to, from microtraumas, from minor muscle strains, minor joint instability that can lead to chronic pain over time. And chronic joint pain affects approximately 10 to 20% of children with joint hypermobility, and it really impacts their daily activities. Among the lower extremities, there are common misalignments among the general population. But if you add on hypermobility, it can really cause strain in the foot, ankles, knees, hips, and even the lower back. So it's important to recognize if your child had a flat feet. 70% of hypermobile children report this. Not the children, the research. Patellar instability, kneecap instability, recurrent kneecap dislocation, quite common among girls with hypermobility. Loose ligament support around the knee can lead to patellar subluxations, dislocations, occurring 10 to 15%, but also quite commonly leads to jumper's knee or quadriceps tendonitis. Hyperpronation, or excessive inward rolling of the feet, often accompanies flat feet in hypermobile children. The knock knee condition, the gain of valgum, where the knees angle inward. And hip dysplasia or hip instability in some cases increases the risk of hip dislocation and subluxations. Obviously, depending on the area where you live in and the access to care, certain locations have very fabulous orthopedic screening for children, and these gets picked up on very quickly and being managed. But certain areas, I see the kids are misdiagnosed, underdiagnosed, undiagnosed for many, many years. And again, you don't have to be an EDS specific physiotherapist to treat these conditions. It just have to be appreciated that it may cause a bigger strain on the foot, ankles, knees, and hips and lower back. So it might need further monitoring and better preventative care versus wait and see. In the upper extremities, what's super common is shoulder instability. And children with hypermobile shoulders may experience recurrent subluxations or dislocations, particularly for those who are playing sports and activities with overhead motion. Now, spinal conditions. This is my area of expertise as a Schroth therapist, working for over 15 years with pediatric and adult population with spinal conditions. So hypermobile children have a higher likelihood of developing idiopathic scoliosis with a prevalence rate of 10 to 20%. This is a recent study, and it was a teeny tiny micro study. Just to give you a comparison, certain populations and races have only 4% of prevalence, and other studies show among the average population as kids and teenagers 13. So this is twice the amount. So hypermobile children, I would say twice the amount of higher likelihood than the average children for developing idiopathic scoliosis. But what is really interesting that in my experience, because the indication is not necessarily the vertebral degeneration, but the lack of soft tissue around the spine, the lack of support for the spinal alignment, the progression rate is way lower. So most of the spinal conditions are below 30% of progression rate. So it's a good outcome compared to the true idiopathic scoliosis. So if the spinal misalignment and spinal deformity develops, it's important that it needs further assessment with a specialist, for an orthopedic spinal specialist and a Schroth therapist. There are other types of Ehlers-Danlos syndromes. I just want to mention this, where spinal deformities are relatively common. And in these scenarios, what I see in my clinical setting is that they're way more severe. So the kyphoscoliotic and the musculocontractural and myopathic scolioses are far more exceeding the conservative management, so they often need surgical procedures. These are just like primary progressing scoliosis, whereas the hypermobile type scoliosis that I see very, very frequently, they, again, typically respond very well to conservative management. They don't progress past the 30%, 30 Cobb degrees. So they are very well manageable with conservative care, bracing, and physiotherapy, specific physiotherapy. So just a quick note about what is really spinal alignment, because not everything is a number causing issue. When we take a look at the spine, we look at three planes: the coronal plane, the frontal view, the side view, and the transverse view, the bird's eye view. And there are two pictures on the right side indicating scoliosis and kyphosis. And there are many, many subcategories and further assessment than just looking at it with clinical assessment or X-ray assessment. But I just wanted to show you what scoliosis means: that there's a side curvature in the spine from the front view, and kyphosis means that there's an increased curvature of the spine. Typically, it's in the thoracic region, but for this study, they use the thoracolumbar region, the in-between between the upper and the lower back. It can also exist in the lower back alone, and the upper back is inverted forward. So we call it scoliosis when the Cobb angle, just to take a picture again, this is the Cobb angle. I'm not going to go into extreme details how do we do this measurement, but if this Cobb angle is 10% or higher, and there is a rotation in the spine, approximately 20% of cases, scoliosis is secondary to another pathological process. So here, think of Ehlers-Danlos syndrome and osteoporosis or neurological conditions such as cerebral palsy or Down syndrome. And the remaining 80% are cases of idiopathic adolescent or juvenile scoliosis. So the vertebral growth is impacted and grows asymmetrically. In EDS, I oftentimes, when I do an analysis of the spine, I don't identify a vertebral asymmetry. So it's more of a spinal misalignment without an actual structural issue. Obviously, in osteoporosis, there is a structural issue, but I also have had many patients over the years with Duchenne muscular dystrophy and other forms of neurological conditions where there was a non-identifiable vertebral asymmetry, vertebral wedging, or a relative anterior overgrowth of the vertebra. So therefore, they did not necessarily have an actual force compressing the vertebra. But in idiopathic conditions, which is most of the cases, a vertebral growth is impacted, and there's an identifiable vertebral wedging and a clear clinical characteristics on the X-ray. And there's also a mix of the two. I have patients, again, who have both an adolescent idiopathic scoliosis and EDS on the top. And how do we know it's separate? Because they have developed it during the juvenile years, where their EDS was not a number-causing issue. And then further along the road, they joined the EDS diagnosis as well. Wide range of prevalence in the general population. So please don't feel special if you have scoliosis, because up above age about 60, 68% of the population has scoliosis, as you are reflecting to gravity, to your felt injuries, surgeries, accidents. So over 2/3 of the population has scoliosis above the age of 60. Okay, so it's important, again, such as with EDS, we don't treat the diagnosis, we treat the human and see, does your scoliosis causing your concern? Does your EDS causing your concern? Okay, so I already talked briefly about this, but again, just because many parents are in the group might be concerning, when do I need treatment? So in the growing spine, a proper assessment of standing X-ray is a must, and the use of physiotherapeutic method called the Schroth method, because this is the scientific evidence all over the world for the past, 10, 15, 20 years. So the Schroth method was developed in 1921, took some time until it arrived to North America and specifically Canada. So anyone over a 20 degree of scoliosis requires bracing and intense physiotherapy. Over 45 degrees considered severe, and most cases it will be requiring spinal surgery. I have many patients with well over 60-degree curvature living a beautiful and balanced life without pain or with minimal pain. So the curves over 45 degree does not mean that they need to be immediately operated. There are many children living with this. And in adults and older adults, if the curvature is over 30 degrees, there's an increased risk of progression. This is how we go from that teenager 10 to maximum 20% up to over 68% of prevalence in the population as we age. And one more note around postural kyphosis, Scheuermann's kyphosis. So the spine from the side view has a backward curvature called a kyphosis in the mid-back, and a forward curvature of lordosis in the lower back. And if there's an increase of this angle, or if a misplacement of this angle and is greater than 45-50 degrees, it can be called hyperkyphosis. And if we also have access to an X-ray, we might see these wedge-shaped vertebra on the X-ray. But it can also commonly develop with EDS. I see this almost, I would say 60% of the cases, and most of the time there's no identifiable wedged vertebrae, but a functional changes that is impacting the spine to be kyphotic looking. Okay, and then finally, the gender and pubertal status. So there was a study by Quatman that titled it The Effects of Gender and Pubertal Status on Generalized Joint Laxity, investigate how gender and stages of puberty affected general population. And gender differences. So females generally display greater joint laxity, especially during and after puberty. Pubertal status significantly impacts joint laxity. Both males and females showed a natural decrease in joint laxity with advancing pubertal stages. So this is great news for those of you who are hoping that your children might be less flexible as they mature. And the study suggests that higher joint laxity in females, particularly during puberty, might contribute to higher susceptibility to joint injuries, such as the ACL ligament injury. So watch out for your teen girls that might need a little bit more, let's say, muscular support for their specific sport activity to prevent these injuries. Okay. And then another interesting study that came out in 2022, gender dysphoria in adolescents with EDS. The objective of this study was to characterize transgender and gender diverse adolescents with Ehlers-Danlos syndrome seen in a very specific pediatric multidisciplinary clinic. So in this clinic, among the 166 total adolescents seen in the clinic during the study period, 17% reported gender dysphoria. 61 of those patients reported their gender identity as transgender, followed by non-binary as of 14, and most had a preferred male pronouns and followed by a non-binary pronouns. This study report the first cohort of transgender and gender diverse adolescents in the Ehlers-Danlos syndrome population and show an association between the two. So now here comes the parents' guide for children with hypermobility. So again, don't forget that the underlying causes of EDS and hypermobility remains unclear, although there are many excellent studies coming out by the day. So we have to stay on our toes to wait for the time when we have clear biomarkers. Clinicians such as general practitioners, pediatricians, physio specialists need to use this new assessment tools with clear diagnostic criteria to reduce diagnostic delay. So please promote the 2023 diagnostic tool and the spider for your healthcare providers, because I still have many patients coming to the clinic being already diagnosed with HEDS, and they recently had this diagnostic tool used, and not the brand new one, but the 2017 one. Currently, treatments are largely symptom-based. So again, until we don't have biomarkers, we have to use symptoms. Clinicians should prioritize personalized treatments in the management of symptoms, such as your child's primary concern is pain or fatigue or dysautonomia. And don't forget that EDS impacts multiple systems, not just your joint and skin and nervous system. So oftentimes you have to work with a multidisciplinary team, which is, I understand, difficult. But why is important to navigate this complex medical condition for your children? So I collected a couple of great examples from scientific researches and education handouts all over the world. And these ones resonated me the most. I'm sure there's many more. So it's important that your child understands why they experience more frequent pain than their peers, why they fatigue more easily compared to others. Explain to them difficulty falling asleep or achieving a restful night's sleep is linked to this condition. They have easily bruising and experiencing frequent subluxations and sprains. They might live with gastrointestinal issues or discomfort, and that is related to hypermobility. They might get sick more often than their peers. They face skepticism and being accused of faking their illness, such as in physical education, they're being told they're lazy and they just don't want to run another circle around the soccer field, yet their ankle is just more sore. They might struggle with social communication skills and navigating social situations. They might experience difficulty with their handwriting, often leading to pain. And they might be homebound or frequently absent from school or activities. So these needs to be discussed as in a family setting and also with your healthcare providers, because it's difficult to navigate a complex medical condition as a child when you don't understand the implications of these medical symptoms. I collected some practical tips for you parents and caregivers. So the hardest part is obviously navigating the healthcare system. So sometimes you have to seek an appropriate specialist who understands hypermobility spectrum disorders and related conditions. It's not always enough to work with your general practitioner, although there are marvelous GPs out there, but you have to sometimes seek for an appropriate specialist. When you think of management at home, try to establish a daily routine that includes, depending on the need, it's not a must, obviously, as necessary, physical therapy exercises, adequate rest, and balanced activities. Implement pacing techniques to prevent flare-ups. Try to utilize early on mobility aids, braces, orthotics, certain ergonomic setups to support their needs. Foster the emotional resilience of your children. Encourage open communication to help your child express frustration, and collaborate with your mental health professionals to manage stress and anxiety effectively. Try to connect with resources. I listed a couple of resources below. Obviously, as EDS becomes more understood, I'm sure that local support, local resources will be far more advanced. But for now, it might be an international and online support. But try to utilize support networks, educational tools, conferences for parents, and try to stay updated with the latest research on managing hypermobility, and as well as the comorbidities such as ME/CFS, dysautonomia in children and adolescents. Try to communicate with the school staff, inform teachers and staff about your child's condition and specific needs, and schedule a meeting to discuss accommodations and support strategies. Emphasize the need for psychological support within the school as well, as children may struggle with feeling different or restricted compared to their peers. Think about modifying physical education classes and work with the PE teacher to advocate for low impact activities and allowing rest breaks during physical activities, as well as pacing. So sometimes your child might be able to run as much as the others, and it's not faking when your child decides that day they are unable to run a single step. In the classroom, try to advocate for flexible seating options. Because of POTS, your child might need to be in a certain position with chairs, back support, or even leg rest or other ergonomic tools for writing and typing. So this is important to discuss with the teacher. Encourage a schedule that includes rest breaks throughout the school day and a flexible attendance policy considering frequent absences. So you might have to educate the school staff why your child has frequent absences or a different attendance to school than others. Also, it would be important to educate peers about invisible disabilities to foster understanding and support, encourage an all open communication how your child is feeling. Remember that there are resources, and you might not even aware without discussing this with the school counselor or mental health professionals. So some academic support, such as accommodation for assignments, extended deadlines, or again, assisted technology for note taking. And here are some international resources, such as the Junior Zebras from the Allerton Society. It's a global learning conference that they have. I'm not sure if every single year. I believe it's not as regular, but you can stay updated if you join their program. So the Junior Zebras program for kids and teens, and they also have, I believe, monthly Let's Chat Teens virtual support groups that offer a unique platform for kids and teens with hypermobility related concerns. And be familiar with the Ehlers-Danlos Society's website, because they have excellent resources coping with school, dealing with family diagnosis, living with ADHD and EDS. So there's lots of yoga for teens. So there's lots of great resources. I copied a picture from the Coping with School with EDS HSD. So you can take a look at these uploaded webinars specific for children and EDS. For those of you who are interested in our monthly webinars and part of this clinic, you can join us in November and December. We will be discussing bowel and bladder issues, as well as pregnancy and menopause. We meet the first Thursday of each month at 3 p.m. So don't forget to sign up for these upcoming EDS monthly group sessions. Okay, so thank you very much for your attention in this very long webinar on pediatric hypermobility related disorders. I am going to take a look at the questions and try to answer them the best I can. So if you stay along, feel free to add more to the Q&A section. And we have 20 more minutes, so I'm looking forward to it. Okay. So the first question was asked is, I noticed flat feet is mentioned. What causes people to have high arches? Ooh, this is a very detailed question. There are structural and functional implications of why high arches develop. So sometimes we have intrinsic issues such as tight muscles or such as asymmetrical bone growth. And other times we have more extrinsic issues like a longer tendon impacting the area. Sometimes it develops as a reaction to the forces that the foot is being impacted by from the ground reaction or from the body. So this would be a little bit more detailed to explain in this short setting. And I'm not sure if you're asking this based on as an adult or as a child. So I need a little bit more details as to how it's related to this pediatric question, okay? But in general, if your child has high arches, I highly encourage to have a proper assessment with a podiatrist and with a pedorthist to see how you can help impact the bones that are still growing, such as the teeth in the mouth needs braces. Sometimes the foot needs orthotics and other support to have lessen these high arches. Okay, next question. If a parent has a diagnosis of HEDS and a toddler just under 4 years old has hypermobility diagnosed by the physiotherapist, but too young to fully diagnose, what do you recommend for physio or exercises or supports to support their body development and lower the risks that come with hypermobility while waiting to be old enough to be properly assessed? Thank you. Perfect question. My recommendation is to work with a pediatric physiotherapist, such as Kids Physio in our community, because they have excellent sources how to bribe them to work with their body in various scenarios. And also don't forget that hypermobility might impact their motor skills and coordination and balance. So it's important that a pediatric physiotherapist performs a comprehensive neurological, orthopedic, vestibular assessment and focusing on your child's unique needs and not just hypermobility in general. And once they are old enough to receive a diagnosis, then you can further advocate for your child to be recognized by other healthcare professionals, to be monitored. I find that oftentimes when there's no number causing stressors, the prevention is, or the support is a little bit of finding a needle in a haystack. So it's better to focus your energies on the things that are a number causing issue. Other than that, follow the World Health Organization's guidelines for kids and teens as how much activity and what type of activity they need, including limiting the high impact activities and the activities that might cause subluxation. Okay. Next question is, are there different considerations for less active children? It's harder to get MSK injuries from reading for hours and hours, although thumb subluxation and neck pain are a real thing. Ha, I love this question. I truly believe that our body, and scientifically too, our body is not designed to rest. Our body is designed to move. So in order to have proper cognitive function, proper bodily function, you have to move your body. This is a scientific fact. And just because a child does not feel the need of movement at the very moment, it's important to foster a very positive and healthy mindset, movement, positivity. And I find that the best way as a parent of a less active child is to find what they actually enjoy doing. So exercise is not a punishment. So keeping in mind that We don't want to include risky sport activities, but it's important for their proper mental and physical development to perform quite a big amount of physical activities. Okay. Next question. Would you recommend reaching out to the pediatrician to have comorbidities assessed before seeing you for an HEDS assessment? So if it's for a child, again, you don't have to have HEDS assessment because the actual questionnaire includes now the comorbidities. And then if the child has a number causing comorbidity included, then we can perform the spider assessment as well. So there's no need to reach out to the pediatrician. We can do it a bit quicker and easier in a physiotherapy setting than to schedule an appointment with a pediatrician. Some of them schedule months ahead. Next question. I missed the adult HEDS session. I am wondering where an adult I know can find out whether they have HEDS. I'm pretty positive they have hypermobility and some of the HEDS symptom. So again, it's a little bit of a bigger answer that you might be looking for. So having an HEDS diagnosis when you suspect it is awesome, but it might not give you the answer that you're looking for as to how to receive care. And the reason for that, because we don't have Ehlers-Danlos association in Canada, we have one in Toronto, but we don't have a local clinical setting where you would be able to see multiple healthcare providers to help you. So if you are suspecting that this person needs extensive musculoskeletal help, I recommend to get this diagnosis more from musculoskeletal perspective, such as a physiotherapist who is confident in diagnosing. I'm more than happy to see this person if they live close by to my clinic. But if you live on other areas of the province, you can always take a look at the Ehlers-Danlos Society's register and see if there's a physiotherapist nearby you who is confident on assessing you. Now, if during the assessment, there are certain number causing comorbidities, skin involvement, pelvic health issues for this assessment, then you might benefit much more from seeing a specialist who can help you with that comorbidity versus a physiotherapist who is not going to potentially able to prescribe you medication and request blood work or an x-ray or any other medical imaging. So it's important to understand where is this person on the spectrum, and to get an adult HEDS diagnosis might not necessarily help you if it's, again, filled out just in one setting or with a person who does not understand the complexity of the diagnosis. Okay? I know it's a little bit of a detouring answer, but it's important that you are not putting all your efforts into the diagnosis, but also like, okay, now I understand this, I suspect this, but then what's going to be my next step in order to help this person? And sometimes, just to give you an example, I see many patients with mast cell activation syndrome, and recognizing that their musculoskeletal complications are coming from another systemic issue is really important, because I'm not going to overtreat the person who needs an internal medicine specialist rather than a physiotherapist. Okay, next question. Hold on, it's a long one. So, my child has been assessed by a sports medicine doctor. He is 9 years on the Beighton. Oh, sorry, my son is 9 on the Beighton scale, has chronic back and leg pain. The doctor told us that he doesn't even have asymptomatic hypermobility. The reason we were given because he doesn't have widespread pain, but he's a full 9 on the Beighton scale. So just to stopping here, your child has generalized joint hypermobility. And since the rest of the questionnaire hasn't been filled out, we don't know if the chronic back and chronic leg pain is a chronic pain actually based on the criteria for chronic pain, or is it part of the musculoskeletal complication? So just based on this sentence of he has chronic pain and chronic leg pain, we need more information. So, but for sure, with the 9 out of 9 Beighton scale, your child has generalized joint hypermobility and a symptomatic. but we need more information to see which exact subcategory we will go to. But the question continues. I have HEDS. The doctor ordered no other tests to understand why my 8-year-old has chronic back pain. I am at loss why this doctor completely wrote him off. Would you recommend looking into another professional to assess them? Absolutely. You have to advocate for your child. Again, in this scenario, we have to rule as physiotherapists or as clinicians, first we have to rule out that there's nothing else that's causing the issue. And this requires performing a subjective and an objective clinical assessment. And based on those findings, we recommend further imaging or further evaluation with a specialist. So this needs to be further investigated. If you would like to, I'm more than happy to help you out with this. If you live farther from me, I would like you to see ideally a pediatric physiotherapist because your child is only 8 years old, or a well-seasoned physiotherapist who is willing to see all populations. But this needs to be completely assessed, both subjectively, objectively, and then further assessments as needed. Next question, is there a certain type of footwear support that is recommended? It is unique to each person. So my recommendation is to have a full assessment with a pedorthist or orthotist. I do work with a lovely pedorthist whose name is Noelle Trotner. She works on the Sunshine Coast. She works, I believe, in Richmond as well, and South Surrey. So if you Google her name, Noelle, she is an excellence of care. And you can look up other pedorthists in your area as well to have a custom, not a custom orthotic, just a footwear, but customized to your or your child's need. Next question. If a child has overpronation, do they need to be assessed? So it's important, again, to be assessed for why is a child performing an overpronation, because it can be just simply functional of certain muscles being developmentally too tight, and also could be a reaction to certain shoe wear or certain misalignment, asymmetries, weakness, tightness. So this needs to be assessed to have an actual accurate answer. Some overpronation needs to be corrected by shoe wear, and some overpronation needs to be managed conservatively with physiotherapy exercises. I recommend, again, in this scenario, working with a pediatric physiotherapist because they are experts at overpronation. And sometimes it's important to mention to them as well that you are suspecting generalized joint hypermobility, so you're a little bit more concerned than the average overpronating child. Okay, next question. How is scoliosis treated? Well, do you have 5 hours? So scoliosis, I had a slide on this, so I'm not sure if I went too fast that the message did not go through or you did not see that slide. So scoliosis needs to be fully assessed because not every scoliosis requires treatment. So it's important first that we know how big is the curvature, how old is the person, and many, many, many other identifiable X-ray, physical assessments, subjective assessments. So scoliosis in general, if the curvature is below 10 degrees, or some people call it 10%, but it's actually Cobb degrees, it is not required treatment, but monitoring during periods of growth spurts. Above 10 degrees, up to about 20-ish degrees, it requires only physiotherapeutic scoliosis-specific management. The most common one is called the Schroth method. And above 20-25 degrees is where bracing is a must, the thoracolumbar spinal orthosis, or TLSO, and that is accompanied by physiotherapy as well. If the curvature is above 45 degrees, then surgical consideration must be accompanied as well. So usually above 20 degrees, the Children's Hospital Orthopedic Spinal Department is monitoring your child as well. And above the age of skeletal maturity, scoliosis still can and often progresses if it's big enough. So then again, it needs to be evaluated. What is the number causing factor in that? Okay. Next question. Should all children with overpronation wear orthotic or supportive shoes, even if they don't have any painful symptoms? I'm going to delegate this task again to discuss with your ped orthist, with your podiatrist, so either foot doctor or foot expert, because there's no general answer to your question. Is there a source I can recommend to the pediatrician for bladder and GI issues? I would recommend you to print out the scientific research that we dissected, both of them today, both the spider and this new pediatric guideline from the Ehlers-Danlos Society's website, because they have great references on common bowel, bladder, and GI issues. And I will try my best to not to forget your question and include in the monthly EDS group webinar as well. So when I will post some sources as well, and I will try to include the pediatric as well. So that's an excellent question. Thank you for bringing this important topic up. Next question, likely our last one. Is there any research concerning hypermobility spectrum disorders and a history of family trauma, ACE, physical abuse, and socioeconomic upbringing? In more severe presentations, it seems that anxiety is prevalent in early childhood. This makes me think that there is likely an environmental emotional addition to the onset of more limiting consequences for the adults who may have had this going on during childhood. The question continues. Stress can affect the body with mysterious ways. I would ponder, since children are expected to go through a myriad of developmental stages, that severe stress might interfere and prolong this hypermobility into adulthood. Since it seems that some level of excess flexibility is expected to be present in young children, that is not expected to be a problem in adulthood. I wonder if this pathway has been explored or ruled out in any way. In the general research, it hasn't been ruled out at all, but in the more holistic healing approaches, absolutely present for a very long time. So there are many studies along Peter Levine and Dr. Gabor Mate as well, where they dissect this topic, not specifically for hypermobility spectrum disorders, but for other disorders. So it is present in the research, but not as directly as the one that we dissected today. So it was very, very beautifully written. Okay, well, we still have time, so I'm going to look at the next question. Have you heard of there being any correlation with excessive teeth grinding and HDS in children? I haven't specifically looked into this in the research, so this is something that I would need to look at. I don't know the answer. Okay, next question. Autism spectrum disorders also observe developmental coordination disorder issues. Do you know if there is also high rates of hypermobility-like disorders in that population? Yes, there's actually a research on this that I discussed with our weekly Ehlers-Danlos group. So I cannot phrase this, but if you specifically search for autism spectrum disorders and hypermobility, you're going to find, I think I went through at least 3-4 very recent studies that are discussing this. So there's lots of correlation, but for now, they are primarily treating them similarly to the ADS comorbidities, the trifecta, as like they commonly occur together and they share a lot of similarities. So it makes sense why they kind of feed into each other, but they haven't fully figured out the true relationship between the two. Okay, I'm going to do one more question and then we're going to wrap up this session. We have HDS in our family. My daughter is dealing with many of the mentioned comorbidities. She has issues with anxiety, sensory, gastrointestinal, bladder, dizziness, fatigue, pain. She's scheduled to see a pediatrician for her issues. How do you bring up HES with the pediatrician, or is there a specialist she can get a diagnosis? She had no assessment so far. So try with your pediatrician since you already have an appointment. Bring the relevant questionnaires that we discussed today And if you are facing any difficulties, which might have happened, I'm more than happy to support the findings as well. It's not always, your pediatrician not always have time to perform a whole hour of assessment. So this is where oftentimes the lack of care coming from, because they just don't have the time for it, and they have to do an assessment and recommendations. They face a lot of challenges with time crunch. So make sure that you present your whole family having HEDS and bring these questionnaires to highlight the newest guidelines, because not every pediatrician is aware yet of these new diagnostic guidelines. Okay, we're all set for today. It was an absolute pleasure to answer your questions. Thank you for your great suggestions and questions. And I'm looking forward to seeing many of you in the other groups as well. Have a lovely rest of the day. Take care. Bye.